So today's blog post is all about the neural hamstring or the neural calf, and I'm getting this kind of terminology thrown about in emails and handovers more and more these days, and I can't help feeling that this neural hamstring or neural calf, it's a slightly lazy diagnosis. And what I mean by that is I still don't think that that's truly identifying the true stressor or the true cause to that patient. And I think it's a bit of a too much of a generic diagnosis, okay? To, you know, if we had 4 players with tight hamstrings or actually that had a pain experience, then, you know, although, yeah, they all might be positive on maybe a slump test, the reason why there is adverse neural tension there is probably unique to that athlete, and it'll be very, very different with each individual athlete, okay? So this neural hamstring, neural calf, I think, you know, as the new age kind of sports physios and understanding the different interactions between the various systems of the body, I think we have a duty to ourselves and the patient to go one step further, okay? So for instance, with this slump test, okay, there's a lot of different things that will influence the tension on the hamstring, okay? And the slump test is only one test that we may use. You might use a straight leg raise, you might use some other tests, okay? But the big thing here is that Alex and his ability to self-organize his system, and Alex's story and his previous injuries and any protective tone or protective tension around Alex's body can have an effect on this test, okay? So for instance, with Alex, and I see this a lot with rugby players, okay, is if we just done a straight knee extension here and we asked Alex, do you have any pain, does it reproduce any symptoms, anything like that? You know, most players would be okay with that. And then if we want to wind them up into this kind of slump test, and let's just start that slump test, okay, for instance. So if we're going to go into this position, one of the first things that's going to have to happen here for Alex is his rib cage has to depress, okay? So when his rib cage depresses, the diaphragm and all those tissues under there and the organs, they're going to start to come up a little bit, okay? That's also going to react with the pelvic floor, with the diaphragm and pelvic floor usually are going to work together, especially in respiration, okay? So if, for instance, Alex had some kind of excessive stress put on his body in training or conditioning, okay, and you'll see a lot of athletes, they'll tend to carry themselves in this position, especially when they're running for a long time, they'll tend to arch their backs, etc. Maybe Alex's system has adapted slightly so that he has maybe lost the ability of these tissues to lengthen as well as maybe he once had them. So if I try to put Alex into a slump position and these tissues are maybe stiff or carrying some kind of protective tone and they don't want to lengthen, then that's going to have a big impact on the ability of that sciatic nerve to slide and to move, okay? So if I try force Alex into that slump position and maybe these tissues don't like it due to this kind of stress response, and then I do this test, a lot of times I will see adverse neural tension in that hamstring, okay? And that then may reproduce Alex's hamstring pain. Now, is it the sciatic nerve here that's causing this hamstring pain, or is it Alex's inability to depress that rib cage due to some kind of traumatic self-organization, okay? And again, in this traumatic self-organization, there's a trauma placed upon Alex's body when he's conditioning, okay? So if Alex is going into extreme fight or flight and he's doing a heavy conditioning session or whatever like that, that is a big stressor on Alex's system, okay? So we have to treat the person as an individual, and that's how maybe Alex has self-organized his body. Then the reactions then kick in, okay? So that would be just one example. Let's say, for instance, Alex took a bang into his intercostal, and again, when I slump Alex here, the tissues around the posterior rib cage, they're going to need to lengthen a little bit. Now, if Alex is carrying protective tone there, that again will have an impact on the ability of that nerve to slide. So again, that response that I'm getting, it may not be the true cause of the problem, okay? Now, if Alex had a previous hamstring tear or genuine trauma to the tissues, then sure, we want to investigate that as well. Then let's look at maybe, you know, trying to identify some things. So again, if I put Alex into maybe an inversion, okay, dorsiflex invert, okay, maybe just a target. So if I extend Alex's leg and then I dorsiflex invert, maybe to try bias the sole nerve, for instance, if Alex had a previous ankle sprain, for instance, and you know, he had some protective tone still present around maybe the peroneus brevis tissues and all those, you know, the skin and the fascia around there, that is also then going to influence the sensitivity or the pain experience or the unpleasant experience that Alex is feeling. Because don't forget that it's not just the nerve that's causing the problem. The nerve is giving information higher up, and it's the higher centers then that are going to interpret this information and obviously then spit out this kind of unpleasant experience. Now, whether that's tightness, whether that's pain, or some kind of other strain sensation that usually our athletes will come in and kind of try to describe to us. Okay, so that's the big thing, is rather than diagnosing this as a neural hamstring, yeah, sure, the sciatic nerve is definitely probably involved, but is it the true stressor to the body? So that's why I'd be very, very careful of leaving it there and stopping with a diagnosis of it's a neural hamstring or it's a neural calf. Okay, but what's driving that neural adverse neural tension in the calf or the hamstring? Okay, so always treat the person as an individual, understand their story, their injury history, what may have caused this adaptation, okay, this motor adaptation to maybe a noxious stimulus, trauma, previous injury, etc. There's a lot of different things that can contribute to the athlete, okay. And again, that stress response with athletes when they're lifting under heavy loads in the gym, when they're doing sustained sustained postures with high level, high intensity exercises. These are two things where the body may have to self-organize in order to keep ultimately Alex's system safe. Okay, so I know this may ruffle a few feathers a little bit, and I was certainly guilty of diagnosing a neural hamstring or neural calf, especially when the coach going, oh, has he torn his hamstring? Oh, no, it's just a neural hamstring or whatever. And sure, yeah, we might tend to throw that terminology out there a little bit with coaches and stuff like that, but as clinicians and when we're talking to each other, I think we've got a duty to ourselves and to the athlete to understand and treat that person as an individual and understand why that athlete is having some kind of neural tension at the moment. So has he got protective tone around maybe the diaphragm, the pelvic floor, intercostals, previous injury? It could be anything, and there's no cookbook recipe for this. It's specific to the athlete and his story or her story. Okay, so the next time you have this neural hamstring, or you're doing your tests, and Shacklock's neurodynamics, Butler's got some great stuff, mobilization of the nervous system. There's some great resources out there for these neural sliders and all these different exercises, but the thing to consider is, okay, sure, we need to do these exercises, okay, in order to help mobilize the nerve, but why is that nerve experiencing adverse neural tension in the first place? That's my question, and that's the thing that I would encourage all the students in my mentorship to look first and foremost at the individual and what's that true stressor that's causing that excessive tension, or the person to experience this excessive tension. Okay, any comments or anything like that? I'm interested to hear what you know. As I said, I've been guilty of calling this a neural hamstring or calf in my earlier days, and just the more I go on now, the more I reflect on this stuff, I think that terminology, it's a little bit lazy, and I'd like just to treat the person as an individual and give the person solutions rather than just label them with this kind of diagnosis of a neural hamstring or a neural calf, but actually find out why that hamstring or sciatic nerve is experiencing this adverse neural tension in the first place. Okay, thanks for listening, and I'll see you on the next one.